All right, we are going to go ahead and get started. Welcome, everyone. You are at the Department of Psychiatry Grand Rounds. My name is Eric Hung, and as one of the co-chairs of the Trainee Research Awards Committee, it's my sort of both honor and pleasure to be able to introduce you to two fantastic speakers and to also to introduce you to part one of two of our Trainee Research Award series. This series has been just a real, I think, sort of highlight of the fantastic research that trainees in our department from across our training programs and across our health systems have been conducting with their mentors over the course of several years. And today it's my pleasure to be able to introduce two of those speakers. In terms of some ground rules for the Grand Rounds for today, everyone is on mute, but we don't want you to be silent. You have a chat feature on your Zoom if you take a look at the bottom bar. And as you have questions for our presenters, I would encourage you to enter those chat features during the presentation and during the Q&A. Each presenter will be speaking for 20 minutes, and we will have 5 minutes for question and answer, and I will moderate the questions from that question and answer. We'll keep to a time schedule of a brief introduction from the mentor, 20 minutes of a presentation from each of our trainees, and then 5 minutes of question and answer. So without further ado, I'm going to turn things over to our first trainee, Dr. Kirsten Bobrow, and then her mentor, Dr. Christine Yaffe, who will introduce Dr. Bobrow for us. Thank you so much.
Good morning, everyone. Thanks, Eric. It's really nice to try and get back to normal, whatever that is. But I was thinking about, the joys of what we do are really learning from one another and I think supporting our trainees. And I couldn't be happier to introduce Dr. Kirsten Bobrow, otherwise known as Kirsty. Kirsty is a public health physician, an epidemiologist who trained in the UK and South Africa. She's South African. She came to UCSF as an Atlantic Fellow with the Global Brain Health Institute. And then for this past year, she's been working with our group in the Center of Population Brain Health, doing some really interesting work on risk factors in South Africa, which she's going to present. Kirsty is particularly interested in social justice and health equality and how these kind of intersect around global health challenges. So she's going to talk to us today about standard and emerging risk factors for dementia in South Africa, trying to understand how you can move towards public health policies to reduce dementia prevalence. So Kirsty, take it away.
Thank you so much, Christine. And I'd also like to thank the department for this award and for having me present my research. And I'm really excited and very grateful for the privilege to be able to present at Grand Rounds. I'm going to share my screen with you now. Okay, and hopefully everybody can see the first slide, which is the title of my talk, which is Established and Emerging Modifiable Risk Factors for Dementia in Low and Middle Income Countries, using South Africa as an example. So very briefly, I have no conflicts of interest to declare. And then just briefly a little bit about my background. Like Christine said, I'm a public health physician and epidemiologist from South Africa. And my work there really focused on translational research using low-cost digital tools to improve health outcomes in people with chronic non-communicable diseases like high blood pressure and type 2 diabetes. And it was really through my work on diabetes and cognitive impairment that I came to work with Professor Yaffe at UCSF, first as an Atlantic Fellow in Global Brain Health Equity, and now as a postdoc in Christine's lab at the Center for Population Brain Health. And building on my work in South Africa on non-communicable diseases, my current program of work really focuses on understanding the role of potentially modifiable risk factors for dementia, which is what we're going to discuss today. So, grounding my work are two aspects. One is a commitment to social justice and health equity, particularly as a South African and having grown up and worked as a healthcare worker in South Africa. And two is a population-based approach, which is really exemplified by the work of British epidemiologist Geoffrey Rose, who basically recognized that a large number of people exposed to a small risk may generate more cases than a small number exposed to a high risk. This will help guide us in our discussions today. So why think about dementia? Well, this clinical syndrome of progressive impairment in cognition and activities of daily living is very prevalent globally, and it's expected to become more prevalent, particularly in low and middle income countries like South Africa. However, the incidence of dementia has decreased in some high income settings, and it suggests then that at least a portion of it may be preventable. In fact, work done at UCSF by Professor Yaffe and Dr. Barnes has shown that as much as 1/3 of cases of dementia may be preventable by focusing on 7 modifiable risk factors, namely diabetes, high blood pressure, obesity, physical inactivity, depression, smoking, and low formal education. Yet, there are gaps in our knowledge base. This slide shows the state of dementia prevalence research worldwide in 2011. And although things are better now, there's by no means research parity globally. And it's very hard to design and test disease-specific interventions when it's still unclear that the burden and distribution of known risk factors is the same in low and middle-income countries as in high-income countries, and that there are not additional risk factors that are locally relevant and that should be considered by healthcare workers and policymakers. My work aims to understand the contribution of risk factors that we think are important, like the established risk factors, as well as risk factors which may be locally relevant and important because of different social and biological patterns of disease. The scale and pattern of disease reflect the way that people live, their social, economic, and environmental circumstances, and all of these can change quickly. South Africa is a middle-income country which has undergone profound changes in the last 25 years. It's a country with high rates of inequality and disparities in health outcome, and it's also a country with a rapidly aging population and increasing dementia prevalence. Similar to other low and middle income settings, the healthcare system is poorly designed to manage a large increase in the number of people living with dementia. And the reality is that any new disease-specific therapeutics are likely to be very expensive and out of reach for most people who would need them. In this setting, population-based approaches are not only appropriate, but also very attractive. The country has several colliding epidemics, including high burdens of HIV/AIDS and tuberculosis, violence and injury, and non-communicable diseases. Population-based strategy is necessary where risk is widely diffused through the whole population. And so for my work, we started with 2 issues that are very prevalent in the South African setting, namely HIV and violence and injury. South Africa has a very large burden of HIV. The adult prevalence is high, it's around 20% in adults aged 15 to 49, and even in those over 60 years, it's around 5%. HIV is known to affect cognition, but since the widespread rollout of antiretrovirals, a lot has changed, and some diagnoses, like HIV-associated dementia or HAD, are now much less common. Now we have large cohorts of people living long and healthy lives and consequently living into ages when dementia is more common. However, it remains unclear whether or not HIV influences the risk of non-HAD dementias. A scoping review showed us that there was very little data available on this issue in South Africa. In fact, to date in South Africa, research on HIV and dementia has largely focused on HAD in younger adult populations and really hasn't included older adults or non-HAD dementias, and hasn't compared HIV-infected and non-HIV-infected individuals. So given the current lack of available secondary data from South Africa, we started thinking about other data sets that could help us address this question. And given that I work with Christine, and Christine works with the Veterans Health Administration, and there is a large nationally representative administrative data set with good exposure and outcome measures, we decided to start by looking at HIV and incident dementia diagnosed in a cohort of US veterans. So these are some of the methods that we used for this study. We studied a random sample of older veterans enrolled in the Veterans Health Administration system. We created a cohort of 1,400 veterans with HIV and matched them to 1,400 veterans without HIV on age, sex, race, and substance use. We excluded people with prevalent dementia during a baseline period of 5 years, and we followed up participants until they were diagnosed with dementia, died, or until the study ended. Follow-up time was up to 11 years and has a mean of 5 years. We found that in this cohort, there is an increased risk of all-cause dementia diagnosis in people living with HIV compared to those not. People with HIV were 1.5 times more likely to be diagnosed with dementia during the follow-up period. This is important. This effect size is similar, if not larger, to other established risk factors for dementia. And although US cohorts with HIV, are somewhat different to cohorts in a generalized epidemic like South Africa, and while we still have more work to do to understand whether or not this risk is primarily biological or socially patterned, we think that this risk factor, because of the size of the effect size as well as the prevalence in South Africa, we think this risk factor is important to continue to explore in the South African setting. Violence and injury are also epidemic in South Africa. Work done at UCSF has shown that traumatic brain injury is an emerging important potentially modifiable risk factor for cognitive impairment and dementia. And although it is thought to be common in South Africa because of road traffic accidents and high rates of interpersonal violence, the actual prevalence isn't known, and available estimates from hospital-based surveys are at least 30 years old. So to address this knowledge gap, we established a collaboration with colleagues from the UCSF Global Health Science School, the Chan School of Public Health at Harvard, and Wits School of Public Health in Johannesburg to set up a survey in an existing study called the HEALTHY study, or the Health and Aging in Africa study, which is a demographic health and surveillance study similar to the health and retirement study in the US, and was established to describe determinants and consequences of aging in South Africa. We worked with our colleagues to identify and pilot a traumatic brain injury survey questionnaire, and we piloted it during the 2019 data collection wave for the HEALTHY study. Some of the results from our pilot work to date: we've successfully adapted the Ohio State TBI survey. This required some local adaptation of things like mechanism of injury, removing things like falls due to ice skating accidents to things like being trampled by farm animals. We successfully rolled it out and used a tablet computer to record exposure status in 630 participants in the study. And our very preliminary results show that at least 17% of participants report a lifetime history of any head injury, and 10% report head injury with some loss of consciousness or a memory gap. Interestingly, most of the injuries were reported in adulthood and middle age, suggesting that there may be some underreporting of early childhood experiences of traumatic brain injury. So very briefly, I've taken you through some of our work to understand emerging risk factors for dementia, which may be locally important in South Africa. But what about some of the established modifiable risk factors for dementia? Well, measures to improve public health may lack the glamour of high-tech technology medicine, but what they lack in excitement, they gain in their potential impact on health because they deal with the major causes of common diseases and disabilities. You may recall earlier, I talked about 7 established modifiable risk factors that are really driving the burden of preventable dementia or the attributable risk. And here they are. Population attributable risk factors are calculated using the prevalence of the risk factor, as well as a measure of the strength of the causal association with the outcome, like a relative risk. And they're an indication of the proportion of disease, in this case dementia, that might be prevented if exposure to the risk factor were reduced. PARs are useful impact measures to translate the public health importance of epidemiological research findings. As you can see, some of the most important risk factors globally are smoking and low educational attainment. Recently, PAR estimates have also been published from, PAR estimates may actually differ worldwide, particularly in low and middle income settings because of differences in risk factor prevalence, differences in things like socioeconomic status, policies, behavior and practices, and genetic predisposition. or differences in the strength of the causal association. And recently, PAR estimates have been published from China, India, and Latin America. And they show this. They show that potentially as much as 50% of the dementia burden may be preventable in some low and middle income settings. And they also show the difference in the relative importance of risk factors across settings. Unfortunately, they didn't include any estimates from countries in Africa. So replicating previously published methods and using published risk estimates for these risk factors, we obtained data from a population-based national survey in South Africa and calculated the PAR estimates for 7 established dementia risk factors in South Africa. Here are those results. The results showed that about a third of the burden of dementia may be preventable in South Africa if these risk factors were addressed. Now, and I'd like to highlight 2 things when thinking about these in comparison to the global PAR estimates. The first is, in South Africa, a greater proportion of dementia might be preventable, and that is without considering what our findings for emerging risk factors that we think may be locally important. And 2, the relative importance of smoking and low educational attainment in driving preventable burden of dementia worldwide. In comparison, in South Africa, we see it's really physical inactivity and midlife hypertension that are driving the PAR estimates. And this brings me to another point that I would like to highlight, which is really how important prevalence is in driving the PAR estimates. As you can see here, when we subaggregate by sex in South Africa, you can see a really striking difference in the PAR estimates for smoking that's driven by the difference in prevalence in smoking between men and women. In comparison, midlife hypertension is prevalent in both men and women, and so the PAR estimates are quite similar. This would suggest that population-based interventions to improve blood pressure control would likely have a big impact on the preventable burden of dementia in South Africa, whereas for smoking, targeting high-risk groups, in other words men, might be more appropriate. So why do we do this sort of work, and why do we present this sort of analyses? Well, much can be done by individuals themselves to improve their own health prospects, but whether or not they will actually take such action depends substantially on economic and social structures for which governments are responsible. So the really key take-home message today is that we need to be very ambitious about dementia prevention. And there are many reasons for this, not least of which is costs associated with dementia are staggeringly high. For example, in 2018 in the US, the costs were estimated at $277 billion, and those costs are projected to only increase over time. And secondly, dementia, because it largely affects older people who are no longer working and who are less socially active, and because it is slowly progressive, is associated with very high social costs, which are often hidden from view. So for healthcare providers who are likely to encounter people with modifiable risk factors, knowing that a sizable portion of dementia might be prevented should galvanize the assertive management of these risk factors. And for health policymakers, knowing the number and distribution of dementia cases that could be prevented by decreasing exposure to known risk factors is key to developing an evidence-based dementia response strategy. It really is critical that we become ambitious about preventing dementia. It's possible, and it can be done with reasonably low-cost interventions. Medications available for things like high blood pressure are cheap and widely available. In terms of myself, next steps for my work include continuing to work on emerging risk factors, including other emerging risk factors like lung function and hearing loss, adding cognitive measures to intervention studies of NCD interventions in South Africa, and then working with existing collaborators to set up and fund multimodal dementia prevention studies. And I would like to take this opportunity to thank my colleagues, to really thank my mentor, Professor Yaffe, as well as my colleagues at the Center for Population Brain Health, other local colleagues and colleagues abroad. I'd be very happy to take any questions. Thank you very much.
Thank you, Kirsten, for that wonderful presentation. So please, I encourage you to put questions into the chat feature. We have 80 participants on this call, which is, I think, a record number for a trainee research grand round series. So I just want to first acknowledge that. While people are thinking of their questions, I also thought it would be great just to thank the selection committee that has brought Dr. Bobrow and soon to be Dr. Wilsley to us today. And that includes Dr. Marina Tulu-Shams, Dr. Andy Crystal, Dr. Susan Vogelmeyer, who's our co-chair, Dr. Steve Hinshaw, and Dr. Christine Yaffe as members of the selection committee. I'm going to manage the chat, and as questions come up, please do not hesitate to raise them. We don't have any questions as of yet, but I do have, Kirsten, one question for you, which is going back to the 1.5 times effect that you see in your HIV sample nationally at the VA. And if you could tell us a little bit about what you think are contributors there, and if there are other aspects such as metabolic contributors or cardiovascular risk factors that are part of that effect or that have been separated out from that.
Brilliant. Thank you so much, Eric, and thank you again for having me. Yes, in terms of the 1.5 times risk factors, I mean, we did have a look at. Sorry, the question was, what do we think is going on there?
Yes.
So I think it's a really great question, and I think we've really started to just start unpacking what we think might be happening. We certainly know that when we compare veterans with HIV to those without, that they do have a different health risk profile, seem to have slightly higher rates of cardiometabolic disease and other risk factors which might increase their risk for dementia, things like substance abuse. And so it's not clear whether or not the risk is being driven by some biologically, some socially patterned additional risk factors, or whether it's being driven by aspects of HIV. We don't think that it's being driven by something like increased access to care. When we compare access to care amongst people with HIV and without, they seem to use care at a similar rate. So we don't think it's just an artifact of the data. And we are doing some more work to try to unpack what's happening with that and how antiretrovirals may impact that.
Wonderful. One question from the chat. What role does social isolation play in dementia in South Africa? And then a kind of corollary to that is, what about racial differences?
Thank you for both of those questions. I think social isolation is a really interesting question. So the social structure in South Africa is reasonably different to what it looks like in the US. We have many more multi-generational households, largely driven by socioeconomic factors and historical factors like a migrant labor system. So it's not uncommon for grandparents to raise grandchildren. And so I think the pattern would be somewhat different. There is some work being done now looking at network patterns for social networks in South Africa, and finds that old adults with lower social networks tend to have a higher risk of dementia than those with more with denser social networks. But this research is pretty new, and because it's already in older adults, it's not yet clear whether or not some of that is prodromal. So you have people who are already starting to have some cognitive impairment and become less socially engaged. In terms of racial differences, so I mean, largely the racial differences are driven by differences in socioeconomic and really structural racism in South Africa. So we still see big inequalities in things like levels of education, things like employment opportunities, which are are probably a really important factor in long-term prevention of dementia, given that our education system is largely limited to primary and secondary school, and we don't have a large numbers of people having tertiary education. And then risk factors are things like smoking. Smoking is much less common in wealthier and also white populations, and is much more common in some racial groups, and that's largely driven by historical factors. So there are important differences in South Africa that are driven by race, but they're because of that we're still recovering from a very racist past, and it's going to take a very long time for us to undo the structural racism that's embedded in the country.
Thank you. So here's a contribution question, and this really kind of pertains across across the range of studies that you've conducted. So is it possible to dissect the contribution of relatively lower IQ, which is highly correlated with education attainment, versus modifiable educational factors, and thinking about risk factors as a whole?
So that's a really great question, and I think South Africa is going to be a very interesting case study going forward. So one of the things that was a feature of apartheid South Africa was really restricting access to education for people on the basis of race. So we have cohorts of older adults who really had no access to education, and that really didn't have anything to do with their cognitive ability. And so we are going to be able to probably see how much of an impact something like education has on risk factor of dementia with a cohort effect once we start comparing people who are in their sort of 50s and 60s now to people who were what we would call born freeze or born in the 90s after the end of apartheid. And that will help us unpack what contribution something like low IQ or low cognitive ability has relative to other sort of risk factors. And I think the thing that's, there are some competing hypotheses around the importance of cognitive reserve and the role that this plays in the risk for dementia. But the short answer to that question is we haven't yet been able to disentangle it. Some of this is just going to come with the fullness of time.
Thank you. Returning to the VA study, what was the role of depression in that difference in HIV positive individuals? And if you could just share a little bit more about how you kind of thought about that, and if depression was adjusted in the models.
Thank you. Yes, we adjusted for depression as well as for post-traumatic stress disorder. And I think it's a really good question. I think there is always going to be some questions about how much of this is driven by associated risks. I think the strength of the study were that it was prospective and we followed people over a long period of time. And we adjusted for depression. I will say it was depression at baseline. So it is possible that something like depression could play somewhat of a role, but in the models, in the unadjusted versus the adjusted models, we didn't see that things like depression were really driving that. We still saw an increased risk that we think is worth exploring more, and we think is maybe causal.
Wonderful. Well, thank you so much. We are at 9 o'clock, so we are going to make our transition over. I would encourage people, for those that see the reactions button at the bottom of your bar, that should be near the chat feature, to give Kirsty a huge round of applause by hitting your applause button.
Thank you all so much.
You're very welcome. Thank you so much for the presentation. So